Cerebrovascular insufficiency. Cerebrovascular insufficiency is an interruption or inadequate blood flow to a focal area of the brain, resulting in transient or permanent neurologic dysfunction. Transient ischemic attack (TIA) lasts less than 24 hours. Ischemic stroke is similar to myocardial infarction in that the pathogenesis is loss of blood supply to the tissue, which can result in irreversible damage if blood flow is not restored quickly. Pathophysiology and etiology. Cerebrovascular insufficiency is caused by atherosclerotic plaque or thrombosis, increased PCO2, decreased PO2, decreased blood viscosity, hyperthermia or hypothermia, and increased ICP, intracranial pressure. Second one, carotid arteries, major intracranial vessels or microcirculation may be affected. Third, cardiac causes of emboli include atrial fibrillation, mitral valve prolapse, infectious endocarditis, and prosthetic heart valve. Fourth, even may be classified as transient ischemic attack (TIA), transient episode of cerebral dysfunction with associated clinical manifestations lasting usually minutes to an hour, possibly up to 24 hours. Fifth one, symptoms persisting longer than 24 hours are classified as stroke. Clinical manifestations of transient ischemic attack (TIA). History of intermittent neurologic deficit, sudden in onset with a maximal deficit within 5 minutes and lasts less than 24 hours. Second one, carotid system involvement, amaurosis fugax, AMAUROSIS, amaurosis fugax is FUGAX. Amaurosis fugax. Homonymous hemianopsia. Homonymous hemianopsia. HOMONYMOUS. Homonymous hemianopsia. HEMIANOPSIA. Homonymous hemianopsia. Unilateral weakness, unilateral numbness or paresthesia, aphasia and dysarthria. Third one, vertebrobasilar system involvement, vertigo, bilateral homonymous hemianopia, diplopia, weakness that is bilateral or alternate sides, dysarthria, dysphagia, ataxia, perioral numbness. Fourth one, carotid bruit. Fifth one, history of headaches of duration of days before ischemia. Diagnostic evaluation. Number 1, cerebral angiography, carotid angiography, oculoplethysmography, Doppler ultrasound, all provide information about carotid and intracranial circulation. Number 2, prothrombin time if anticoagulation is considered. Number 3, diffusion weight and MRI may be done to rule out stroke. Number 4, transesophageal echocardiography to rule out any emboli from heart. Management. Platelet aggregation inhibitors such as aspirin and ticlid, that is ticlopidine, to reduce risk of stroke. Surgical intervention to increase blood flow to brain, carotid endarterectomy, extracranial intracranial anastomosis or angioplasty. Third, reduction of other risk factors to prevent stroke such as control of blood pressure, diabetes and hyperlipidemia and smoking cessation. Fourth, anticoagulation thrombolytic agents for patients who continue to have symptoms despite antiplatelet therapy and those with major source of cardiac emboli. Thrombolytic agents include streptokinase or recombinant tissue plasminogen activator 3 to 5 hours after onset. Complications. Complete ischemic stroke. Alert: extracranial intracranial anastomosis is used for focal areas of ischemia. Pressure over the anastomosis of the superior temporal artery extracranial and the middle cerebral artery intracranial can result in rupture or ischemia of the site. If the patient wears glasses, remove the valve on the operative side to avoid the possible pressure point. Thank you.